Welcome back to another episode of Critical Care Time. If you missed it earlier, I am still Dr. Nick Mark.
And coincidentally, I'm still Dr. Cyrus asking, bringing you the podcast for everyone who cares for the critically ill.
We'll try to cut to the chase here. This is part 2 of our reboot series on undifferentiated shock.
In this episode, we introduce the conceptual framework we use to assess and teach shock to our trainees. So it's the idea of the pump, the tank, and the pipes. We'll break down what that means in terms of a critically ill patient and how that framework can help you figure out what kind of shock your ailing patient is in, and really more importantly, how you're going to help them.
Yeah, so this is actually the first real episode we had on the channel. We've had a lot of growth since we launched. So for many of you, this may be your first time hearing this foundational content on shock that we refer back to frequently. And for those who have been with us since the beginning, this should hopefully be a fun refresher, and hopefully our jokes are still funny.
Yes, we certainly hope so. And also for those of you that are fans of the show, we appreciate your feedback. We appreciate you guys listening. So thank you so much. Thank you for everything. We listen to what you guys say. We try to incorporate that. And also, I'd just like to take a second to also thank our sponsors who have been with us since season 1, C-Star Medical. You guys help us keep the lights on, so we sure appreciate that. Thank you very much.
Without further delay, let's get on to our reboot of Undifferentiated Shock Part 2.
Ultrasound, may not give you as many clues that are specific that this is distributive shock. It'll show you a hyperdynamic ventricle. It will show you a variable IBC findings. It will probably show you A lines in the lungs. But occasionally it'll really come through for you, and you may spot something like, a thickened gallbladder or something like that can really not only support the etiology of shock, but give you a very specific cause.
Welcome to Critical Care Time, the show for everyone who takes care of the critically ill. I'm your host, Dr. Nick Mark, and I'm joined by my co-host, Dr. Cyrus Askin.
Nick, it's great to be here, and it's even greater to see that you've had a little bit of a wardrobe change since we were last recording. Tell me about that.
That's right. So in that half-hour break we took, I didn't actually exercise, but I put on exercise clothes, hoping that when we finish this episode, maybe I'll actually get my ass on the bike.
I love that. I kind of do the same thing too. And I have to say, I'm also a fan of the Peloton, the sort of like COVID-19 Wall Street darling that it was.
Yes. Yesteryear, darling. This year, not so much.
Not so much, but hey, still a great workout. Do you have a particular, what do you like about the Peloton?
I have the row and the bike, so I'm way too into the Peloton. But yeah. I really like erging. I like the power zone. I basically just couple Peloton with TV. So like if I'm gonna watch, old episodes of ER or The Wire or something, it's like I only get to do that when I'm on the bike or rowing. So it's a good behavioral coupling technique.
I love the that's next time we do this, we'll have to talk about The Wire, because that's like one of my all-time favorite shows. And I'm thankful.
Mine too.
I'm thankful for my buddy and other podcaster and physician, Austin Baraki, for forcing me essentially to start watching that. And then I was like, oh my gosh, where has this been all my life?
Best TV show ever made.
It's so good. But yeah, no, I'm a big Peloton fan too, especially here
what's your handle?
So I am Psy Guy, the Fly Guy.
Nice.
But I understand that you have a far better handle.
I don't have far better. Kreb_cycling.
Oh, God, you're such a nerd, dude.
Some jerk got there before me. I had to use the underscore. It's kind of heartbreaking. It's all right.
Well, it's like if that's the greatest adversity you face, then you're doing something right.
It's true. If I had to pick some more obscure biochemical pathway, that would have been really heartbreaking.
Yes, you're right. That would have been truly heartbreaking. So I think we probably wasted enough of our audience's time. We should probably get started. For the uninitiated, this is part 2 of our episode on shock. In part 1, we talked about what shock is, essentially insufficient oxygen delivery.
And what shock isn't. It's not a specific blood pressure.
And so now that we have a better understanding as to what shock is, in part 2, what we're going to do is really try to give you that framework for understanding shock.
Right. There are dozens, if not hundreds, of things that can cause shock. Everything from valvulopathies to arrhythmias, hemorrhage to adrenal insufficiency, sepsis, pneumothorax, poisoning, tamponade, spinal cord injury, PE, and many, many more. Instead of just trying to memorize this vast list and kind of run through it every time you see a sick person and try to figure out what they have, we need a framework. We need a way that we can conceptualize all of these dozens of causes of shock into a framework that you can use on the fly very easily. And so we're going to break it down into basically 3.5 categories. And we're going to talk about it from the lens of hemodynamics, physical exam findings, and point of care ultrasound, so that you can figure out which category your patient falls into. So we'll talk about what those categories are. Spoiler alert: cardiogenic, obstructive, distributive, hypovolemic. And then we're going to double click on each of them and talk about what the findings you would expect in each are.
So kind of just a word, I guess, on why we think the frameworks are helpful is really, like in many things, medicine isn't different in this regard. It can be helpful to have these sorts of heuristics or cognitive shortcuts that gives us the ability to be more efficient, make life a bit easier, maybe get home to your family an hour earlier than you otherwise would after a long shift. And so, initially we've kind of given you that introduction material, and now we're going to go ahead and talk about the framework we like to use to sort of stratify our shock patients. So without further delay, Nick, do you want to kick us off?
Absolutely. So the framework that we like is sort of break this into 3 categories of problems: a pump problem, a pipe problem, or a tank problem. A pump reflects the heart, and that could be either a cardiogenic shock etiology or an obstructive shock etiology. What those two have in common is that they both affect cardiac output as the primary problem, but one is intrinsic to the heart and one is extrinsic to it. Second, pipes, which is distributive shock, many different etiologies in there. Here, the primary issue is a decrease in afterload or systemic vascular resistance. And then finally, a tank problem or an empty tank problem, which is hypovolemic shock. Many different etiologies in here as well, but what they all have in common is they have inadequate preload, so low filling pressures. And if you use this framework, you really only have 3 or 4 categories of problems to look for, and you can figure out which of those categories your patient is in, and then you can quickly get to treating them while you're figuring out what the exact etiology is. So it gets you past the differential phase and to treatment much faster. So let's talk about the first one. Let's talk about the pump. So you could think about this, like I said, as kind of a problem with the heart itself or a problem that's affecting the heart. So problems with the heart itself could be an issue with rate or rhythm, could be an issue where you have inadequate contractility, either of the right or left ventricle. It could be a problem with your valves, like wide open MR, ruptured chordae, et cetera. It could be something that's kind of globally affecting the heart, like myocardial contusion or toxins.
Thanks, Nick, for kind of introducing the concept of the pump. Hemodynamically, we expect cardiogenic shock to be characterized by decreased cardiac output, which shouldn't come as a shock, in association with increased filling pressures. So CVP should typically be elevated, as should the pulmonary capillary wedge pressure. Additionally, these folks will typically have increased afterload or an increase in their SBR. The reality, though, is while it's nice to talk about this stuff in theory, we often don't have these numbers readily available. So, Nick, in your practice, what other findings might clue you into pump failure? What other tools do you use in the toolbox?
So, I mean, first off, and we should say this for all of them, is just context, right? Knowing somebody's history, glancing at their chart, knowing what their EF was 6 months ago is a great hint. So don't assume that you're doing this in a vacuum. You often have strong priors based on their medical history. But you take those priors, and then when you go see this person, you're going to use the physical exam. So looking at things like their skin, their neck veins, their pulses, the pulse pressure, as well as ultrasound findings. So we're going to look at the heart, the lungs, the IVC, and other organs. And we're going to put all of that together to come up with a clinical gestalt. And let's say we start off and we know this person has a history of heart failure, but then our exam and ultrasound findings point us another way. Well, we can ignore those priors and come up with a new diagnosis. Conversely, sometimes you'll see that somebody, has, what was described as a minor problem. And when you actually do the exam, you realize that actually, no, they're now in, frank organ failure. That problem that was noted 10 years ago is now life-threatening.
I think that's great, Nick. Thanks for fleshing that out. So that's kind of like a nice little overview for how we approach that pump failure. Specifically, are there clinical findings that you would expect to see in a patient? Can we maybe make sure we've done them due justice?
Absolutely. So we'll often see the effects of low cardiac output. So we'll see cool extremities with delayed cap refill. We might see evidence of volume overload, either in the form of edema for extravascular volume overload, or we might see increased filling pressures like high or jugular venous pulsations. So all of this can suggest that hemodynamic picture. It's worth remembering, though, that heart failure can come in different flavors. So you can be cold, hyperperfused, or warm, and you can be wet or dry. So none of these is an absolute rule in, rule out. It's more like something that tweaks the probabilities a little bit.
Do you use any other adjuncts typically in these folks? I mean, I suspect EKG is very helpful, kind of as an upfront diagnostic. I use them all the time. I suspect you do as well.
Absolutely. I think, you're going to have telemetry, and getting a 12 lead 2 gives you a lot of useful information about the heart. You can spot a lot of structural abnormalities. You can spot arrhythmias. In conjunction, a chest radiograph, a chest x-ray is very valuable. You can see if the heart is enlarged. You can see if the pulmonary vasculature is engorged. You can see what the lungs look like. There's a lot of, if there's effusions, there's a lot of information to be had with 2 very common routine tests, just an EKG and a radiograph.
Perfect. And I think, for those of us that work in ICUs, or those of us that work really with patients well, now I'm frankly quite prevalent in all avenues of practice, would be point of care ultrasound. And certainly these folks could benefit, I think, from getting an exam. And typically in our cardiogenic shock patients, you can see things like evidence of decreased ejection fraction, which you can either measure via an LVOT VTI that you can use to then determine cardiac output. You could also look for evidence of septal thickening on systole, suggesting that you're actually having, good sort of cardiac contractions. And then, of course, you can make that global assessment of EF, although those also can be notoriously poor in regards to accuracy. So you just have to be careful there. And then on the other side, on the right side, typically things like a decreased TAPSE, or that tricuspid annular plane systolic excursion, might be worrisome. You can also see apicolization of the right ventricle, or again, you can make that global assessment of RV function or dysfunction, as it were, and sort of go from there. Outside of that, Nick, anything else that you look for in these cardiogenic shock patients as pertaining to POCUS or other modalities?
So I think POCUS is really, really, really valuable here. There's just so much you can get. So to amplify what you said, Cyrus, like, you can look at the LV function by measuring LV efflotract VTI. You can also use EF measurements. Sometimes some of the newer ultrasound machines will actually use machine learning to measure that for you, which is pretty cool. You can measure RV systolic function using TAPSE. And then you could look kind of globally at wall motion. Does it look like there's a wall down? You can look at valves. Does it look like there's wide open MR? Does it look like there's really severe stenosis? The key thing to remember is that you're not a sonographer. You're not trying to exactly grade this. You're trying to identify life-threatening abnormalities, which shouldn't be solved, right? Somebody who is in shock from a massive MI is probably going to have a pretty conspicuous decrease in their VTI, and a pretty conspicuous, wall motion, or walls that are not moving properly. There's a few other things we can look for too. So like apical ballooning and Takotsubo cardiomyopathy is a surprisingly common one. And then, as a pulmonologist, we can't forget the lungs. So make sure to look for the presence of a beeline pattern or pleural effusions, which can also be indicators of a cardiac etiology of shock.
That's awesome, Nick. I think that's a great point that you make, that, we aren't professional radiologists or professional sonographers. We're trying to answer a clinical question at the bedside. And so, we do the best we can in that moment to make those determinations. But oftentimes I find, like in my own practice, I will do what I need to do at the point of injury, so to speak, and then get a formal study. And that will both give me more information and engage, a colleague in cardiology or what have you. But the added benefit is I can compare my findings to what they found and kind of see how close I was. I don't know if you do that as well.
And I find that one of the best motivators to get, a cardiologist to activate the cath lab for me in the middle of the night is to FaceTime them and show them what I'm seeing.
That's awesome. That's a great little trick. So, moving on from kind of specifically cardiogenic shock, we know that a lot of the hemodynamic findings are similar in cardiogenic shock and obstructive shock. But when it comes to point of care ultrasound, let's say, how might your exam change in someone who has obstructive shock?
So obstructive shock is kind of etiologies of shock not to miss is a good way to think of it, right? These are the things that are often very treatable if you diagnose them. And point of care ultrasound and physical exam is a great way to diagnose them. So for example, if you look at the lungs and you see bilateral lung sliding, you can largely exclude pneumothorax. Whereas if you see, one-sided lung sliding and you could find a lung point on the contralateral side, that's extremely suggestive of pneumothorax. So that's a life-saving diagnosis you can make with the ultrasound machine. You can, especially with subcostal views, you can very quickly evaluate for pericardial fluid, and you can look at some hemodynamic properties to look for the presence of tamponade. And then, the PE, there's a lot of information that you can get from ultrasound there. So, for example, you can see that the RV is dilated. You can see that taxi is decreased. You may see evidence of a clot in transit, which is essentially pathognomonic for PE. And then there's the so-called McConnell sign. This is right ventricular free wall akinesis, where the apex is still moving. So it kind of looks like somebody is jumping on a trampoline. It's going up and down. And this is not sensitive, but fairly specific. So if you see it, it could be a very useful indicator of what's going on. Finally, we should turn our attention outside of the chest and look at the whole person. So if you see leg swelling, particularly unilateral leg swelling with your eyes, that's a big clue. And then you can take your ultrasound probe and you can go looking for that clot. If you find somebody with evidence of RE failure, cardiogenic shock, who has a clot in the lower extremity, that's a very suggestive story for obstructive shock due to pulmonary.
And so I think before moving on from the pump, as it were, probably not a bad idea to talk about some specific examples and then foot stomp any of the ones that we really think are critical. So when it comes to cardiogenic shock, obviously, the first thing that comes to mind is that acute MI, that big LAD infarct that results in LV failure, acute LV failure. In a similar vein, you can have acute exacerbations of heart failure, of course. So a person has pre-existing heart disease and then something tips them over and they come in, as we were saying, warm and wet, cold and wet, what have you. And really probably the most dramatic cases are those that have known systolic heart failure, at least the ones that I've seen. Moving on from that, certainly traumatic causes. So traumatic cardiac injuries, blunt cardiac injury can cause cardiogenic shock. Additionally, you can have valve failure, papillary muscle failure, papillary muscle rupture. And then, as you said, Nick, those arrhythmias that can be tachycardias or bradycardias, they can really sort of limit your ability to effectively perfuse by sort of impairing either the heart rate component of cardiac output or reducing your time in diastole and thus reducing your stroke volume. Nick, do you want to talk a little bit about obstructive shock?
Very well said. Yeah, so with obstructive shock, the big ones are tamponade, where we can often see fluid around the heart, tension pneumothorax, where we can see the absence of lung sliding and see a pneumothorax on one side, PE. But there are others, and we should probably mention a couple other causes too. So one that can cause obstructive shock is critical aortic stenosis or LV outflow tract obstruction. So if your heart is unable to eject blood into the systemic circulation, this is a diagnosis that can be readily made with point of care ultrasound if you know what to look for. Using a continuous wave Doppler through the outflow tract, you can see a sort of late peaking pattern described as a dagger shape. And then one last cause of obstructive shock that people tend to forget about, which drives me a little crazy as a pulmonologist, is dynamic hyperinflation. And this is not necessarily something you're going to diagnose with ultrasound, but this is something you can diagnose with your hands and your stethoscope or just your eyes. And what's going on here is if somebody is having significant asynchrony with the ventilator or they're not having enough expiratory time, they can get more and more inflated with each breath. And that can cause very, very high intrathoracic pressures, which compromise filling and outflow. And that can lead to a obstructive shock light etiology. This is also very easy to treat. Just disconnecting them from the ventilator is often enough to release that pressure, and then making some bed changes could prevent this from occurring again. So add that to your list of causes and you'll never forget it.
That's great. That's definitely a good one to remember. Now, before we move on, Nick, I kind of have this question that I always wrestle with a little bit, maybe more of philosophical question. So when it comes to pulmonary embolism, particularly, which I'm certain we'll do an episode or maybe multiple episodes on in the future, I kind of think of it as a hybrid form of shock within that sort of pump category, because you certainly have that obstructive component, but at least the way that I understand the pathophysiology there, it's often you have obstructions secondary to that increase in PVR that causes RV failure that then sort of often will cause issues with coronary artery perfusion to the LV, and then also physically that physical obstruction of the LVOT by way of bowing into the LV. What are your thoughts on that?
Absolutely. I mean, I think some people don't even really differentiate obstructive and cardiogenic shock. They think of them as sort of one category. And I think it's totally reasonable to think of both together as a pump problem. I guess the difference is really, do you define that pump problem as being with the heart itself, or maybe with the flow into or out of the heart? So for example, if there's a big saddle embolus blocking outflow causing the RV problem, it's a little bit of a semantic difference. I think the key thing to understand is that these are two big categories that hold many etiologies, and that these two categories share very similar hemodynamics and many of the same physical exam and ultrasound findings.
Perfect. That's a great way, I think, to keep that section and move on to the pipes. So when we talk about the pipes, of course, what we're referring to is distributive shock. And like kind of pump failure, the pipe failure, if you will, or distributive shock does come in multiple flavors. The hallmark of distributive shock is a reduction in systemic vascular resistance, or SVR, and that's due to pathologic vasodilation. In these folks, initially, we'll often see an increase in cardiac output due to an effort to sort of protect the map, as one of my attendings used to say, defend the map. And then the CVP and the pulmonary capillary wedge pressure are sort of hard to predict in these patients. It's not always one or the other, because there are other factors at play. So sometimes that drop in SVR,
and that, by the way, is why CVP is a bad resuscitation endpoint.
Absolutely, yeah. It's more complicated than just take full, tank empty. It's a pretty good measure, I think, of right atrial pressure, but it's certainly not a good barometer for volume responsiveness. So yeah, and as I was saying, so sometimes that drop in SVR can prompt a drop in CVP, and then you can give volume to potentially make up for that, but really the fact that sort of distributive shock by definition is not a low volume state is why giving liters and liters of fluid isn't usually a great move. That's not to say someone can't be kind of quote unquote volume down, but just giving them liter after liter of fluid to try to fill up the tank that's gotten bigger, so to speak, isn't really the right answer. So there are medications, specifically vasopressors, that can actually be used to increase that pathologically decreased SVR. So all that being said, Nick, any comments on that, or do you want to move on to bedside finding?
Before we do, I want to just emphasize one point, which is that often, especially in the medical ICU, people tend to say distributive shock as synonymous with septic shock. And I really want to draw a distinction between them. Sepsis is the most common cause of distributive shock, but there are other important etiologies in this bucket. So for example, anaphylaxis, cytokine release syndrome, fat embolism. You can also see a very similar pathophysiology in people where they don't have vascular tone for neurological reasons. So like with a spinal cord injury, severe TBI, or somebody who's receiving neuraxial anesthesia with like a thoracic epidural. So, and we also very frequently see people who have distributive shock related to things like liver failure, where their liver is not metabolizing vasodilators, so those accumulate, or in people who are like post-cardiac surgery, where they have produced a lot of exogenous vasodilators because their blood was exposed to a membrane. So I think my key takeaway here is don't view distributive shock and sepsis as the same thing. Often they might have both, but you really don't want to miss those other etiologies. Like if somebody's having anaphylaxis to a drug you gave them, or if somebody's got another underlying problem like liver failure, or they're getting sedative effects of medications. So, view these as related, but one is a larger bucket than the other. Let's talk about the hemodynamics of distributive shock now. So the unifying characteristic of all of these etiologies is a low systemic vascular resistance. And we'll see this a couple different ways.
if you remember from part one, we talked about pulse pressure. If you feel their pulse pressure, it's going to be widened. Their pulse might feel bounding. What you're feeling here is that their vessels are very compliant, and their cardiac output is causing them to distend a lot more. So you can actually feel that with your fingertips. People who are in a high output state, a high output shock state, will often be warm and flushed, at least initially. And that's one of the differentiating features when you feel somebody's skin if they have distributive shock. Then there's a lot of point of care ultrasound findings. So you may actually see a hyperdynamic left ventricle. That can be an interesting clue. You might also find a specific etiology if you look. So you might find, where an infection is if you do a good ultrasound exam. So ultrasound, may not give you as many clues that are specific that this is distributive shock. It'll show you a hyperdynamic ventricle. It will show you a variable IVC findings. It will probably show you A lines in the lungs, but occasionally it'll really come through for you, and you may spot something like, a thickened gallbladder or something like that can really not only support the etiology of shock, but give you a very specific cause. Cyrus, so we've already talked a bit on the differential. Anything else you want to add to distributive shock?
Yeah, so as you said, sepsis is or septic shock is often inappropriately interchanged with the term distributive shock, but as you pointed out, it's certainly the most common cause, at least that we see in the medical ICU, if not other ICUs, probably all ICUs, to be honest. And for our audience out there, the really sort of impressive cases tend to be those with gram-negative uremia, or those that have fungemia. Those are the folks that can get really kind of rip-roaring sepsis, and then distributive shock as a result, or septic shock. As a result. That all being said, there are certainly other etiologies that we want to consider, as we sort of mentioned. So things like anaphylaxis to medications, or to things like bee stings, other environmental factors, hyperinflammatory conditions such as severe pancreatitis, liver failure that you touched on, as well as acute and or severe endocrinopathies, things like adrenal insufficiency or thyrotoxicosis. And then finally, there's sort of the concept of neurogenic shock, which I found confusing, and I feel like I always need to revisit it because it is one of those things that that can be a bit tough to understand because of some of the verbiage, I think. But with neurogenic shock, typically what we see is either a spinal cord injury or severe TBI that causes autonomic disruption, in addition to some sort of like focal neurologic deficits or what have you, typically. But that autonomic disruption will manifest as bradycardia, hypotension, and temperature instability. So those are things to look out for in those folks.
Yeah, I think it's important to remember all of these other etiologies of distributive shock, especially in somebody who isn't getting better with treatment for sepsis. Or
Absolutely.
in somebody where you just haven't found other evidence to support a diagnosis of sepsis. Like they don't have a leukocytosis, their cultures have all been negative. These are the patients where you really don't want to miss, like, for example, an endocrinopathy as the cause.
I think that's a great point. And now that I'm thinking about it, that we talked about neurogenic shock, but one of the other terms that often that's thrown around is spinal shock, and this may be a good opportunity for us to differentiate the two for our listeners. So, Nick, do you want to talk a little bit about neurogenic shock in some more specific terms?
Neurogenic shock really reflects the situation where you've lost sympathetic tone, exactly as you said. So your blood vessels are vasodilated from lack of sympathetic tone, and your heart is often bradycardic with less squeeze from lack of that sympathetic tone. That's very different than just having a spinal cord injury, and it's also very important to differentiate that will only happen with very high spinal cord injuries because the sympathetic chain branches off relatively high. And so you won't lose sympathetics with a thoracic spinal cord injury, for example.
Exactly right. Yeah, and I think that's with spinal shock, which is, like I said, a term that's often confused with neurogenic shock. You'll have loss of motor and sensory function below the level of, let's say, a significant spinal cord injury like a transection, and that can result in temporary loss or blunting of spinal reflexes at and or below the level of the injury. But that's not necessarily associated with loss of autonomic functions in all comers. Those folks aren't necessarily going to have that bradycardia, that hypotension, temperature instability. And so it's, the way I think of it is kind of like you can certainly have spinal shock and neurogenic shock can occur in the same patient, but you can also have spinal shock occur sort of separate from the manifestations of neurogenic shock, particularly for those lower injuries, as you mentioned.
That's great. Yeah, I'll admit that I used to mix those two up a lot. So very good clarification. Yeah,
Thanks.
thanks for emphasizing that.
Every
Um,
once in a while, a blind squirrel gets a nut, Nick. So, but yeah. So that being said, I was wondering if maybe you could bring us home and talk a little bit about the tank.
Yeah, so we've already talked about pump problems, cardiogenic and obstructive. We talked about pipe problems, that's distributive. Now we're going to talk about tank problems or hypovolemic shock. Um, and it's really important to remember just how many different ways you can lose fluid, how many different etiologies are inside this bucket first. So first of all, you can lose blood. That's especially bad because you're losing volume and oxygen carrying capacity. We call this hemorrhagic shock. You can see this with surgery, with trauma, GI bleeds. You can also lose fluid without losing blood. So you can lose fluid into the environment, like skin losses from burns or just heat injury. You can lose fluid into the GI tract, like with diarrhea and vomiting. And you can lose fluid renally, either osmotically, like somebody with DKA will lose a lot of fluid from that, or with specific like salt and fluid wasting pathologies like hypoaldosteronism or iatrogenically from diuretics. And then finally, you can lose fluid not out of your body, but into your body, so-called third space. Essentially, the idea is that fluid is shifting from the vascular space, where it provides preload, to the interstitial space where it does not.
The thing that sticks out to me there is this whole third spacing thing. Isn't that like a dated term?
Yeah, it's funny. I think there are some authors who are trying to move away from the term third spacing, either because they think it's confusing or because they don't think it's accurate. Either way, I guess the third space has been canceled. But wherever that fluid goes, it is possible to lose fluid out of your vasculature where it doesn't leave your body.
Okay, I like that. That's perfect.
So Cyrus, can you tell us about the hemodynamics associated with hypovolemic shock?
I would love nothing more. So the good thing, I suppose, is that the hemodynamics are pretty straightforward when it comes to hypovolemic shock. So your preload is going to be down. So your CDP and your pulmonary capillary wedge pressure should be down due to that volume loss. What's interesting is so cardiac output will initially increase, although once preload has descended to a critical low, your stroke volume is going to be hindered. And in fact, to a point where heart rate can't compensate. And thus, over time, if left unchecked, you can see a drop in cardiac output in these folks because they're just not able to compensate from a heart rate standpoint. We know that systemic vascular resistance will rise to maintain the MAP, but that's usually not sufficient, given that the problem is one that requires a volume to solve.
And so it's important to recognize that hypovolemic shock, or tank failure, if you like that, requires the tank to be refilled. Vasopressors do act as venoconstrictors. They'll constrict the venous side, which will increase your venous return and raise your effective circulating volume. But that's really temporizing. That in order to solve the problem here, you have to replace volume, either blood that's been lost or fluids that have been lost.
That's exactly right. So, Nick, what do you look for clinically when you're evaluating patients with that are suspected of having hemorrhagic shock or some other type of tank failure?
So often what we'll see is somebody who's tachycardic. They have a delayed cap refill. If you look at their neck veins, they're often flat. If you feel their skin, it's often dry, sometimes like bone dry. There's a great physical exam finding that the lack of axillary sweat is actually a very useful physical exam finding for identifying hypovolemia. Yeah, we talked a little bit in part 1 of this episode about how shock index can be useful. As a quick reminder, shock index is heart rate divided by systolic blood pressure. It should normally be about 0.5 to 0.7. In people with hypovolemia in particular, you often see an elevated shock index. That's that, as you said before, that's them compensating with increased heart rate for a low preload, essentially low cardiac output.
Perfect. And I think, Nick, to round things out, maybe I can talk a little bit about point of care ultrasound and maybe get
Absolutely.
your thoughts on this. So, just like all the other forms of shock, we often will use point of care ultrasound. Hypovolemic shock is no different. And as an aside, I'll say here before I forget, um, we are sort of, for the purposes of discussing this, using these silos, but recognize that oftentimes different forms of shock can coexist. You can have multifactorial shock. I just want to make sure people realize that these are not independent of one another.
Right. They're not mutually exclusive.
Not at all. Absolutely. So anyway, getting back to the point of care stuff. So in hypovolemic shock, we would expect again to see hyperdynamic LV and maybe evidence of underfilling. You might see an IVC that's diminutive with significant respirophasic variation, so greater than 50% decrease in the diameter with inspiration. And then when it comes to pulmonary ultrasonography, I typically see what's called an A-line profile in these folks. And what that means is the A-lines are essentially a reverberation artifact of the pleura. And so in the absence of consolidation of the lungs, in the absence of B lines, aka significant fluid in the lungs, you can see that reverberation artifact clearly as being basically a series of parallel lines. And those are what we call A lines.
And we should clarify that, for our listeners, that we'll have videos on our YouTube channel showing you these things too.
Absolutely.
We're basically assuming some level of at least familiarity with these terms. If you don't know what any of these terms mean, there will be more content to round out your knowledge. Remember, this is a framework. We're going to go much more in depth on all the different aspects.
The last kind of composite POCUS study I'll mention is what's called the EFAST exam, which is super helpful in hemorrhagic shock, and oftentimes can actually help us help us determine where the blood loss is occurring. Do you want to talk, Nick, a little bit about what that EFAST exam looks like?
Yeah. So the EFAST exam can tip you off to a lot of different pathologies. So there's an adage often in the ED that there are 4 places where you can lose enough blood to die, or 5 places depending on the chest, the abdomen, your bilateral femurs, the retroperitoneum, and if you want a 5th, maybe the floor. You can lose blood out of your body. You don't need POCUS to see that last one, but for those other causes, the FAST exam or EFAST exam can be very helpful. So looking at the chest to make sure there isn't fluid accumulation there, looking at the abdomen to make sure there isn't fluid there. Unfortunately, point of care ultrasound is not great at visualizing the retroperitoneum. So especially in patients where you have a pretest likelihood that they could have an RP bleed, so for example, somebody who's had instrumentation in the cath lab or IR, who's now suddenly hypotensive. This is a situation where you might need to think about other imaging beyond point of care ultrasound in order to identify that site of hemorrhage. And specifically, the CAT scanner can be your friend. If the person is stable enough to go, this can give you the answer and show you where the blood is.
And just to sort of reiterate, while the donut of truth for is always a great place to send a patient if you don't know what to do. Point of care ultrasound can be very helpful. The EFAST is very helpful. And so, Nick, kind of like you were saying, typical EFAST is going to be looking at the pericardial space to try to identify any evidence of tamponade. You're going to look at the splenorenal recess, the hepatorenal recess. You're going to look posterior to the bladder. And then finally, you're going to look at the lungs to see if there's any evidence of pneumothorax. And again, like you said, we're going to try to post some content to YouTube and perhaps elsewhere to help folks understand this a little bit better.
That's right. And sometimes the FAST exam can really be a win. You might see something like an ectopic pregnancy, aortic dissection, large aortic aneurysm. There's pathologies that you can see on this that can absolutely clue you into not just confirm that they're likely hypovolemic, but tell you why they're hypovolemic, which points you to your next step therapeutically.
It's sometimes easier said than done when it comes to discerning the sort of type of shock that we're dealing with, and especially when there are multiple types of shock at play. And again, that's why I think it's so important to have a methodical approach that allows you to sort of collect data and interpret data quickly with the goal of initiating the appropriate treatment as quickly as you can.
Absolutely.
So,
I
so
think
with
that's
that,
I think that's a perfect place to leave it. In fact,
yeah,
I think that's a
absolutely.
great summary.
I think so too. I think that's a great little summary. And I hope Nick, I hope you had as much fun with this episode and the previous episode as I did. I think this is some pretty high yield stuff, and I hope our audience likes it too.
Yeah, and I hope they look forward to more, because there's definitely going to be a lot more on these topics. We basically, just scratched the surface today. Look out for more videos and more podcasts on many of these topics, where we can go in greater depth.
Absolutely. Well, with that, you've just finished another episode of Critical Care Time. We hope it was, as I said, as much fun for you as it was for us. Follow us on Twitter at Critical Care Time, on Instagram at critical_care_time, or on YouTube via our Critical Care Time channel. Check out our website at www.criticalcaretime.com and subscribe to our mailing list, where we will keep you updated on all of our comings and goings.
We are fortunate that this episode, like all episodes in season 1, is sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more. Also, if you enjoyed this episode, please give us a like, write us a 5-star review, and subscribe to our show through whatever your favorite podcast platform is.
And before we go, we'd like to thank our incredible team here at Critical Care Time. Our podcast staff is awesome. Thank you guys for making this show possible. We would also like to thank our production team over at Podpaste. And last but certainly not least, Kurt Belknap for our awesome theme music. Thanks for listening, and we'll see you next time.
This podcast and all related media, included but not limited to animations, graphics, and videos, are the property of Critical Care Time. We would love for you to enjoy this and share with your friends, or even modify it and use it in your own teaching. We just ask that you cite us and tell them where you got it. The views expressed within this podcast and any associated media do not reflect the views of our employers or any of the staff members, friends, or guests of the show. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities are totally coincidence. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking actual medical advice.